Hey guys, welcome to Life with Juan again. It's me, Juan, and we're playing another chapter in this game called Prognosis. This one is called Burned, and as you can tell, it's about burn injuries. So let's cut to the chase. A 15-year-old girl is brought in 20 minutes after being rescued from a burning house. She was asleep at night when a spark from a faulty phone charger started a fire, leaving her trapped in her bedroom. Her medical and surgical histories are unremarkable, and her carbon monoxide hemoglobin level is found to be at 7%. So this is a bit high. Normal is around less than 3%. So let's look at our physical exam. Generally, we have superficial second-degree burns, over 8% of her body surface area. We have deep second-degree burns, over 5% of her body surface area. And we don't have any third-degree or circumferential burns. We don't have any facial burns. We have a patent area with no swelling. We have soot in the nasal passages and in the mouth. Generally, her vitals, she's tachycardic and tachypneic. That means her heartbeat is fast and her breathing is fast. She's in pain. Her GCS is 12/15. That means, okay, that's a mouthful. That means her eyes open spontaneously. That means, her voice, V3. Okay, she responds weakly. And then M5. That means her movement is weak. Okay. How do I say this? Weak movements, weak voice, and her eyes are no problem. No problem with her eyes. Her eyes open spontaneously. Her weight is 50 kilograms and her height is 160 centimeters. All right. Let's investigate. Which of these should we do? I'll definitely do an ABG. I'll do an ABG. Okay, normal pH. CO2 is normal. PaO2 is normal. Carbon, bicarbonate is normal. Okay, let's look at the chest x-ray. Let's look at her lungs. Normal x-ray. Fiber optic bronchoscopy. Should I do that? Okay, yes. No laryngeal or tracheal edema. Should I do a complete blood count? Well, we do this in all patients that I've seen so far who get admitted to the ER. But I'm not sure. Should I do it? Let's do it. Okay, so we have a high white blood cell count. Hemoglobin is 13.5. Hematocrit is 41.5. And her platelets are 370. Okay, let's go to our management. I don't think we should intubate because there's no laryngeal edema. Definitely referring to a burn unit. Escharotomy. That means we're going to cut off the burn tissue. I don't think I want to do that. I'll give her IV fluids. Okay, were my choices correct? Let's do this. Oh, almost there. 2 stars. Okay, let's see what I did wrong. Okay, I should not have done the bronchoscopy. But everything else was pretty good. Okay, let's see the explanation. The emergency physician is typically the first point of contact for a burn patient, has a crucial role in emergent management. So hence, they should follow the Advanced Trauma Life Support Guidelines. Okay, I did not read that. Okay, primary survey is always airway, breathing, circulation, disability, and exposure. Okay, so first, airway. Assessment of her airway reveals the presence of soot in the nares, hinting that inhalational injury might be present. The fact that she was trapped in her bedroom prior to being rescued adds to this possibility. So it's essential to appreciate that patients with inhalation injuries may suddenly and rapidly develop upper airway edema. Edema. I have no idea how you would prefer me to pronounce that. Please let me know in the comments. Thus, further evaluation in this regard is mandatory. Right, so we definitely need to evaluate further. Fortunately, her airway is patent. That means it's clear. no obvious swelling, and she's not in respiratory distress. A chest x-ray does not show features of inhalational injury, and ABG is normal. Thus, immediate intubation is not indicated, though she should be under close watch for respiratory distress. Then, while assessing her breathing, it should be appreciated that patients trapped in a closed area are at risk of carbon monoxide poisoning. So, standard pulse oximetry is unreliable in this setting. Instead, a carboxyhemoglobin level should be obtained. Fortunately, a level of less than 10% does not necessitate further specific therapy. Burns may result in significant fluid loss. Therefore, close assessment of her circulatory parameters is essential. This reveals the presence of tachycardia, delayed capillary refill time, and tachypnea. The constellation of findings is suggestive of grade 3 hypovolemic shock. Okay, thus, large bore IV access should be established and fluid resuscitation commenced immediately. Proper exposure is the final step of the primary survey. All clothes should be removed and all orifices visualized. Total burn surface area should be accurately estimated along with the degree of burns. TBSA in this patient is 13%. Let's go back. Let's see. Oh, I can't see. Total is 13%. Burns being superficial or deep secondary. This meets the criteria for referral to specialized burn unit. Note that fiber optic bronchoscopy is performed to determine the extent of airway compromise in patients with features of inhalational injury. It's probably not indicated here because we don't have any airway edema. Finally, escherotomy would have been indicated if third-degree circumferential burns were present. Okay, we don't have those, therefore, no need to do escherotomy. Right. Each year, over 1 million individuals in the U.S. seek care for burns. While the majority of these are minor in nature, nonetheless, severe burns are an important cause of hospitalization, death, and long-term morbidity. The detailed management of burns is well covered in guidelines such as the ABS, American Burn Society. I'm not sure if that's like a legit acronym. Correct me if I'm wrong. Thus, this text will only attempt to convey some of the important principles involved, mainly focusing on thermal burns. In order to understand how to manage burns, one needs to both appreciate the structure and role of the skin, as well as understand the pathophysiology underlying a burn injury and the potential complications. So there are two layers of the skin, outer epidermis and inner dermis, which are separated by a basement membrane. These protect against physical injury and microorganisms, prevent fluid loss, and aid thermoregulation. While superficial burn injuries involving only the epidermis are fairly well tolerated, deeper burns disrupt the function of the skin, resulting in local and systemic disturbances. In particular, large burn injuries initiate a systemic inflammatory response while also stimulating the sympathetic nervous system, as might be appreciated. This results in deleterious effects to almost every organ system. Of particular importance is the increased capillary permeability and intravascular depletion induced by the inflammation. This predisposes to hypotension and hypovolemic shock, as well as to oliguria and acute kidney injury. Right, in a nutshell, fluid loss because of the inflammation. So, strict IV fluid resuscitation should be done. The sympathetic overactivity predisposes to gastric stress ulcer formation and ileus. It also induces a catabolic state which may impair healing. Adrenal stimulation may give rise to hypercortisolism, with subsequent hyperglycemia and insulin resistance. Note that also, that's a mouthful, I'm sorry. The systemic inflammation may give rise to an immunocompromised state, predisposing to secondary infection. Initial evaluation and management of these patients should be guided by the ATLS guidelines, i.e. primary survey, ABCDE, followed by secondary survey. As with other conditions, primary survey should be focused on identifying and treating life-threatening injuries. The burn itself takes a back seat at this point. Important considerations during the primary survey include early recognition of inhalational injury and airway compromise, close evaluation of the circulatory parameters to detect if shock might be present, prevention of hypothermia, particularly in children, in whom there is a high surface-to-body mass ratio, and proper fluid resuscitation. Secondary survey should be performed as a burn-specific survey. Important considerations here should be determining if carbon monoxide intoxication might be present, if the patient was in a closed area, and if examination revealed soot in the mouth and nose, and detection of circumferential burns. Common pitfalls include missing corneal burns, which should be suspected if there is facial involvement, missing rupture of the tympanic membranes in individuals whom the burns are secondary to an explosion, and missing perineal burns, which may subsequently be auto-contaminated by urine or feces. Basic lab investigations should be obtained, include a full blood count, which we did, arterial blood gas, we did, renal functions and electrolytes, clotting profile, CRP, CPK, blood glucose, and serum albumin levels. Quantification of TBSA is essential in managing these patients. In adults, Wallace's rule of nines is widely used. So essentially, that's each part of your body constitutes around 9% of your body surface area. So that's 9% for the anterior arm, 9% for the posterior arm, 9% for the anterior lower extremity, 9% for the posterior lower extremity, 9% for the anterior torso, for the posterior torso, and wait, did I get that right? 9, 18, 36, 45, 54, 63, 72. Okay, yeah, and then 18% for the torso. Now you might be wondering, where's that 1%? The groin. Yes, it's hard to visualize with just me talking, but you can look that up. However, the rule of nines is less useful in children because they have larger heads compared to adults. So we use the Lund-Browder chart for kids. Burns identified should be categorized according to the depth, first degree, second degree, and third degree. So it's either minor epithelial burns, complete epithelial burns, and epithelial damage with dermis damage. The American Burn Association recommends that patients with one or more of the following should be referred to a specialized burn unit. Second degree burns, third degree burns, burns that involve the face, hand, feet, genitalia, perineum, major points, inhalational injury, burn injury, in pre-existing medical disorders, in patients who require special social, emotional, or long-term rehabilitation, burns and concomitant trauma, children in hospitals without qualified personnel, electrical burns, and chemical burns. So, fluid resuscitation is the cornerstone of management. The Parkland formula has been traditionally used. It's now superseded by the 10th edition of ATLS, which recommends a volume of fluid of 2 ml times the patient's body weight times the total body surface area burns. So in our patient who weighs 60 kilograms, total body surface area is 13%. So it's 60 times 13% times 2. What's 13? Alexa, what's 13% of 120?
13% of 120 is 15.6.
Right. So we need that many ml, 15.6 ml. This should be provided in the form of lactated ringers, with one half provided over 8 hours and the remaining half over the subsequent 16 hours. Right. It should be appreciated that this formula is only a guide, so this should always be tailored to the individual patient. So other important aspects of management include definitely pain control, preventing hypothermia, deep venous thrombosis prophylaxis. That means preventing any blood clots that may go flying into your heart or your brain. Prophylaxis against gastric stress ulcers, prevention of secondary infection, proper nutrition, and monitoring of vitals and urine output. Rehabilitation is important and should begin ASAP. Note that surgery may be indicated in certain patients, especially with third-degree circumferential burns, while wound debridement may be required in patients with deep second-degree or third-degree burns or if burn contamination is present. In addition, early wound closure by skin grafting or dermal substitutes or matrices can be considered if a large burn area exists. Synthetic substitutes are on increase in use. Can be considered. Okay, I didn't get the grammar of the last sentence. But the take-home message is, initial management should proceed according to the ATLS guidelines. Eye, ear, and groin burns are often easily missed. Proper fluid resuscitation is a cornerstone of management. And finally, people with severe burns should be referred to a specialized burn unit. And there you have it. That was Burned on Prognosis here on Life with Juan. How was our playthrough? How did I do? Please tell me if you have any comments. Tell me if you played this level before. And why don't you go ahead and download this game, Prognosis. You can find it on the iTunes App Store and on the Google Play Store. This has been Life with Juan. And as always, please like, subscribe, comment on this video, and stay tuned for future videos. Till next time, live life to the fullest, because you only have one life to live. Alexa, I didn't call you.
Na 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 na.